Any thoughts how you would deal with this?
I mean, I would get a plastic surgery consult to begin with. I think the earlier you get them involved, the better.
All right. So this is what was done. We combined it with the spacer. At the same time, the plastic surgery colleague came, rotated a medial gastroc flap. This was with the skin graft applied, and that's the wound at 4 months, nearly healed. That small area went on to heal. So whenever you see these type of multiple incisions, scars, etc., I think it's a good idea to get your plastic surgery colleague. Do not try and go in without adequate skin cover. All right, so let's move on to this case. 62-year-old female, pain in her left TKR, which was done roughly 10 years ago. ESR 43, CRP 7.68. How would you approach this? Start, maybe Harish?
The X-ray looks like there is some osteolysis below the tibia. There is maybe some osteolysis behind the femur. It might have become a little loose. A CT scan may help us to identify actually amount of bone loss which is there. If there are, ESR is not very high, I mean it's non-specific, CRP is normal, but still it is not a bad idea to get an aspiration, find out the cause. Is it aseptic loosening or aseptic? So aspiration culture may help us out. And depending on what we find, we have to proceed accordingly.
Okay, so we did aspirate and it was negative for aspiration. How would you proceed now? Ashok, any thoughts?
So around 10 years in situ, there is a varus collapse. Almost inevitably, there would be some amount of polyethylene wear, some amount of osteolysis. CT scan is not mandatory. It would help to try and evaluate the bone loss. You've already excluded infection. Would go in, explant, evaluate the defects, deal with the defects, restore your alignment, and go with the minimum amount of constraint that's needed for stability.
So where do you think the problem lies? On the femur, on the tibia, where?
I think it's in the poly.
In the poly, okay. Rajesh, any thoughts?
Because the fixation appears to be good. It certainly is in a significant varus, and the osteolysis probably, but I would do maybe CT or MR and see if any of that is seen, osteolysis, then you know it's the poly wear causing that. The other possibility is this pain of a recent origin?
Yes.
Is there something on the post that is causing this? The post wear or the posterior medial wear on the poly, which we can't see here? One of those two things.
It's a fairly obese lady who progressively continued to have pain, and this is many years after these knees were done somewhere else. But she was having persistent pain in her left knee.
Yeah, I mean, you can see the extensive synovitis in the suprapatellar pouch. As you mentioned, the alignment suggests that it is in varus. You know, if you had some older x-rays, you could get a sense of what's going on. My suspicion is that it's falling into varus. The femoral component's probably loosening. Yeah, she's going to need a revision.
Yeah, exactly.
You can see she's obese. I mean, there's several issues that are at play here.
Yeah, so I think the point that Amar raised is very important. If you can track down the old x-rays, then you can compare what the implant position is like, whether it started off like this or whether it's collapsed into varus. And as Amar rightly pointed out, it was only the femoral component which has gone into varus. So we did an isolated revision only of the femoral component. The tibia was well fixed. We changed the poly. So now this brings me to the question, and it's open to all the panelists. Would you do an isolated revision like this if the other components are absolutely pristine, well fixed, well aligned? Or would you do a complete revision? What's your general take?
If I did the knee, I would consider doing an isolated exchange. If someone else did the knee, I generally will start over and do everything else. In this case, the tibia, you know, I'll assess it. I know this system. I can remove the system relatively easily and just cement inside cement if I had to, but I would want to make sure that, the fixation on the tibial side was also, solid. And so, a lot of it has to do with timing of things too. If this knee failed, this was 10, 15 years, okay, I'll be a little bit more forgiving. If the knee failed in 3 or 4 years, I'm taking everything out, even if it looks good.
Yeah, so the time frame is important. Any other points anyone would like to bring up? Otherwise, we'll move on.
The tibial component was slightly invarus. Wouldn't you like to change that? Or would you like to leave it?
Well, it's survived for 10 years. There's no change on the...
She is a quite obese patient. Minor malalignment may cause sequential extra, wear.
Harish, that's in kinematic alignment.
Okay,
So,
Parag told us no more.
If I plan to retain this, I would definitely do an MRI and see the fixation on the tibial side. I'm sure probably you
Yeah,
did.
we done a CT scan and confirmed that there was no loosening on the tibia.
Arun, the message should be, I think we should be prepared to do both in case you find
Yes.
it to be well fixed. So be prepared to do the both.
Absolutely. And we also send this bio-fire stuff, so even though we've aspirated, we still send it during surgery for whatever it's worth, just to be sure that there's no infection. Because this sort of loosening, sometimes osteolysis can be mixed up with loosening, septic loosening. All right, so now we move down to the tibia. So this was a bilateral total knee in a very obese patient. You can see the soft tissue shadow. The right side, she started complaining of pain 4 years post-op. Yes. Any thoughts at that end, from the far end?
The tibial component is loose. There is a bone loss on the medial condyle of the tibia. I'm not sure about the femoral loosening. So it could be a case of, again, because she's only a 4-year post-op, only a tibial revision, if the infection workup is negative.
So how do you deal with this now?
Single stage, if the infection workup is negative, remove the tibia, see for the stability of the femoral component. And I think a medial augment with a stem tibia will do the job.
So a stem and an augment. Yeah, let's go down the line. Your preferred choice, full revision or isolated revision if the components are all right.
If I have to dislocate the tibia, I bring the soft tissue releases. Usually there could be some inequality between flexion and extension gaps. So doing just one may not be possible, but if it is possible, I'll just try to put a trial tibial component, see exactly how it works with remaining of the femur. If it gaps look good and if there is no instability, maybe I can just do a tibial revision. But it's important to know that tibia change will just change equal amount of flexion and extension. If I have to do single femur, it may be little easy because I can add augment, I can downsize, and then I can match by flexionation gap by just one component revision.
Since it's just 4 years, I would, although the infection is not there as far as the blood parameters are concerned, but I will still treat it as a infection because the duration is too short, and I may do a 1.5 revision of the tibia alone, and if, on the femur as well. Yeah, I will use a lot of antibiotics inside the canal and outside as well.
So you're treating it basically as an infection.
Yes, because
Okay.
I feel it's too short.
I would aspirate it first. As a routine, all revisions we do aspirate.
Oh yeah.
If it is aseptic, then I'll be prepared to do the both. But if the femur is good, then only the tibia with augment and stem.
So isolated revision if not infected. Ashok? And what will you use as your implant? Will you, what will you use, a stem?
Stem with augment, most likely there'll be a half wedge would be required. And maybe varus valgus constraint type of, but for that I'll have to go to the femur also. We'll change the femur. So I'll be prepared to do the both in case everything is stable and I can get away with a semi-constrained kind of an implant. So I'll just do the tibia, do the bony stability thing and just get.
All right. Ashok?
I would certainly like to see earlier x-rays in this particular case. The femur is in valgus. That doesn't sit right. The tibia is obviously loose. You've excluded infection. This might be, if there is a progressive deformity, this might be what they call the insufficiency fracture. It's a PS design. So femur, tibia, stem, possibly an augment on the tibial side.
Rajesh?
Yeah, I think the key thing is to see if the femur is in good alignment overall on the long leg X-ray and how good the fixation is on the table. Tibia, probably I would use a sleeve. And because I think there is a lot of cement in the proximal part, I'm not sure. So I'll keep both the things ready, augment and a stem and a sleeve. I wouldn't mind doing a single component revision if everything else looked good with just the tibia revise. What I would do though is, the reason why this has failed is either the original tibia was in significant varus or the medial collateral was not balanced well and it has failed. So I think we do need to address it, find out what was the reason, looking at the earlier x-rays, and then balance the knee. Even the revision can fail. I would try and use a mobile bearing if I can with the MBT tray here.
Amar?
Yeah, as I mentioned before, somebody else did this knee. It failed in 4 years. I'm taking everything out. On the tibial side, I'm going to use a sleeve and a stem press fit. On the femoral side, I'll probably just do hybrid fixation with a cemented stem, no sleeve. I'll have the opportunity then to use increased constraint if I need to. But the knee will then be, perfectly aligned and stable. And with this lady and her obesity, I'm going to, double down on fixation, make sure everything's good.
All right, so we aspirated this. We went through the x-rays. There's no change on the femoral component. Femur seemed to be well aligned, rotated. That's what we did. We used a cone and a stem, which was a longer stem with cement. So, any comments? We find very often that these are very short females with a very small size of tibia, and very often getting a sleeve into these is not very easy. You can end up fracturing these patients with the sleeve. The preparation is not very easy with these.
Yeah, well, I mean, I think the way to prepare it is you can't use the broaches. You have to use a high-speed burr. And you literally burr it out and prepare it that way, and then you use the broach just to sort of size it.
Right.
But if you just, you try to broach it, broaches are used for cancellous bone. You can't do sclerotic bone or cement-filled bone. So yeah, I manually machine it myself, and then I get the sleeves to fit in.
Okay. This lady came 12 years after her surgery, 60-year-old rheumatoid, ESR 25, CRP 4.5, with significant instability of her left knee. She had already had a problem on the right side, which had been revised for a similar instability, and she came back on the left side for a similar problem. How likely do you think that this is due to her significant nerve compression, that she's developed a neurological problem and gone into late stage instability? And what would you do for it? Start this end now, Amar.
Yeah, I mean, I think she should definitely get a spinal evaluation. She's going into hyperextension now. This knee is grossly unstable. She's probably headed towards a hinge, in my opinion. And so I would have the spine evaluated, decide if they need to have that decompressed first, and then be prepared to do a hinge when the time comes for the knee.
Any differences? Anyone would like to add anything?
I would get nerve conduction studies in this particular patient, and I'm thinking on the lines of neuromuscular instability. So hinge would be in my mind while I'm going to revise this case, but nerve conductions, I would definitely get it done before I touch this patient.
This instability will not be because of muscle weakness, which result from maybe nerve compression in the lumbar spine, because it is going to be specific 1 or 2 muscles, and that also may not be complete because patient otherwise would have gone for surgery for that. So this is basically because it's wearing out, and maybe ligaments have become a little loose, lax, and I don't think there should be much of a muscle-related issue. But anyway, you should get the spine problem sorted out first by decompression, and then address the TKR revision, depending on the amount of defect which is there.
What is that screw or
There's
wires?
a retained implant from the original surgery.
Oh, okay.
Some fragment there which was left behind there. Okay, so yes, we did an EMG, we got a spine consult, we did an MRI of the spine which had revealed all of this, and spoke to her, and that's what we did. We put in a sleeve, stem, and we've changed everything on both sides. But as you can see on the femoral side, while her bone is pretty soft, and we probably penetrated the anterior cortex at some point, and you can see some cement exuding out from there. Any thoughts as to whether should we be worried about that or ignore it? We didn't notice it at that time.
Yeah, I would plate it.
Plate it after you notice it? Anyone would just wait and watch?
It is a definite cause for worry, no doubt, but I don't think at this stage we can do anything, but we should be worried, and she may fracture at this.
Okay, so I think these are some of the issues that we see when the femur is significantly bowed, and we are trying to put in a longer stem, a straight stem. So that's one of the occupational hazards. All right. So since we hadn't had a chance to
Plating it now is a very easy thing to do. Plating it later, once it's fractured, is a much more challenging thing to do.
Yeah, we probably need to talk to her and see whether prophylactically we need to plate it. So just quickly to just summarize the most recent paper on the subject of sleeves versus cones, because we really haven't had a chance to discuss this. So this is over 2,000 cases that have been reviewed. Generally, loosening is slightly more with cones, so also periprosthetic joint infection is slightly higher after cones. The revision rates or the re-revision rates for cones is slightly higher. The clinical scores are comparable, and people tend to use a hinge prosthesis more frequently in the cone group, and the CC type or constrained prosthesis are seen to be more frequently used in the sleeve group, looking at over 2,000 sleeves and cones in this study. So just a brief summary of that. All right, let's now move to periprosthetic fractures. Again, something which was covered in the master class, but not in these discussions. So this is a lady who 1 month after her surgery had a fall, and this is the X-ray that you can see of her immediate post-op, the scanogram, and this is after her fall. So how would you tackle this? Start from the far end.
I think the issue in this case is now the collaterals are in jeopardy because of the condyle fractures, the epicondyle fractures on both the sides. I'll be worried about the bone quality, and I think we have to explant and need a higher constraint implant in this, like a rotating hinge.
Any differences, anyone? Anyone would like to fix it?
How old is the patient?
How old is the patient?
This patient was, I think, in the 75-80 age group.
Bone
Sorry, I
quality?
missed out. Bone quality, not great.
I would still like to fix it. Maybe plate on both sides. If the joint is stable and when you're going inside, if the femoral component is still holding on very well, I think fixation is an option here.
Okay.
This would be one of the cases where I would do the stacked cones with a hinge. We've done a fair number of these, reported it. They do really very, very well, particularly for these sort of comminuted distal femoral fractures. Put 2 tantalum cones, long stem, breastfit. Use the fragments as a graft around that. The amount of new bone that forms at about 6 months is phenomenal. And you've got early mobilization. You don't have to worry about fixation options. And from a bacterial point of view, bacteriocidal.
The only problem was this was 2010, long time ago. It's an old case. So we didn't have access to that paper. You hadn't written it by then. Rajesh, any thoughts? Fix versus replace?
I think the quality of the
Revise.
bone will decide whether dual plating can be done. Doesn't look like, because the fracture is very much distal and both the condyles are fractured. So I would err towards taking everything out, and maybe a sleeve will work. But if not, I'll keep the distal femur replacement ready.
Okay.
Tibial cement tells me that the bone is pretty porotic. Cement has really spread into the tibia.
Okay. Amar, any difference?
Yeah, I mean, I mentioned yesterday, I think the amount of distal femoral replacements that we're doing now is going way up. It's a reproducible operation. Patient can weight bear right away. So we're doing less and less fixation and more distal femoral replacements.
All right. So somebody attempted to do this wherever she was, and obviously it didn't really have any chance of working. And so we did exactly what you said, a distal femoral replacement. All right, this is another one. This happened a month after her right total knee. The only difference was that this was a patient with very severe valgus, where we done a sliding lateral osteotomy, and you can see the two screws which were there for the sliding osteotomy, and then she fell and fractured in this manner. So anyone wants to take this on? Harish.
Bone looks very osteoporotic, and there is a bicondylar fracture quite close to the implant, so there won't be anything to fix, I think, even if you use the bicondylar plate. So it need to be replaced with something like a hinge or a tumor prosthesis.
All right. Any differences?
I mean, I would do what you did in the last case.
The last case, yeah. But by this time, I had now read what Ashok had written, and we got a little tempted. I, in fact, spoke to him before taking up this case, and we put in a sleeve a cone, and cemented it into this, keeping the entire soft tissue intact. Protected her in a long leg knee brace, and that's at 6 months. As he said, you get fantastic bone formation on the medial side. The lateral is the epicondyle, which is not very relevant, but the rest of the fragments have united very well, and she's standing, walking, and has an excellent range of motion at the end of it. So this perhaps is a very good option in some cases where you can do this, as Ashok has described. So you need not necessarily fix it, and you need not necessarily replace the distal femur either. Okay, this patient showed up 10 years later. This was done by Dr. Dholakia many years ago, and she showed up with this at the age of 80 with bilateral knee pain and instability. Yeah, Rajesh, some thoughts?
Yeah, so I think I guess the right side is clearly osteolysis. Both the components appear to be loose. Tibia definitely has migrated too, so needs a full revision. Patella may be okay. On the left, I'm not able to judge, but I'm sure there is osteolysis under the femoral component that at least you can see whether tibia is loose or not. So the right, definitely a full revision, maybe retaining the patella, and left probably the same if the full X-ray can be seen.
So this is what we found at the time of surgery: massive osteolysis from polywear, and you can see the ice cream cones on either side, femur and tibia, with large defects. So now how do you address these defects? What would you do? This was, of course, about 10 years ago, before we had access to sleeves.
I think
Today,
sleeves.
if you were dealing with it today, what would you do?
Sleeves, I think such a cone, still you would be able to get a sleeve to have a good fixation, because there is a metaphyseal flare which is still available. And I think on the both sides, you should get a good fixation with the sleeve with an additional stem, and more likely just a constrained implant but it'll depend on how good the stability is. I don't suspect that the stability should be a problem here.
Anyone, any difference of opinion? All right, so this is what we did, a sleeve with a more constrained implant with the stem going all the way up. On the other side, we use an MBT, TC3 combination.
But you're cementing these sleeves in.
You can cement these sleeves. The smallest size is meant to be used with cement.
Yeah.
The smallest size of sleeve. And that's her. She's now almost close to 90 now. So almost 10 years following this and doing quite well. And this is the last case. Parag, can I finish off with this last case? All right. This was a lady who came, this was one of the earlier cases that I had done. Freeman Samuelson, which I think a few people might recognize. This is one of the earliest cases that we had done and presented with this.
All polytibia.
All polytibia with those two magic pegs of Mike Freeman and presented with this X-ray. 50-year-old, very obese with rheumatoid arthritis. Start from the far end. Any thoughts?
Managing tibial bone loss is a big challenge here. So I think use of a sleeve, building up the tibia, restoring the joint line, and a complete revision. On the femoral side also, I think the bone quality will, because of RA, will require a sleeve.
And what about the extensor mechanism? How do you take care of that?
Didn't notice that.
Because it's avulsed, right?
Yeah.
The tibial tuberosity, insertion of the patellar tendon.
I think there is significant devastation of the upper end of the tibia, including the attachment of the patellar tendon. So we'll have to use something like a tumor prosthesis, which will have attachment for the distal end of your tibial tendon, which can be attached into the position. We just have to be careful that there is no infection underlying. We have to aspirate that. And does this patient have any other medical problem like
Only
elephantiasis
rheumatoid and obesity.
obesity?
And rheumatoid.
Okay. Because the bone looks very bad and destroyed quite a lot. So infection is one which you have to worry about. But it has to be tumor prosthesis which has attachment for the anterior tibial tendon attachment.
Yep.
We might have to look at a graft, either a semi-T or something, to get it fixed lower down if there is no attachment to the femur, because you can't leave the patellar tendon hanging loose, and of course we have to go with a completely constrained implants.
Okay. So in the interest of time, that's what we did. And we fixed that with a wire. And I think we also used the semi-T to reinforce the tendon, patellar tendon, a sleeve stem with a rotating platform TC3 insert, and revised all the components, including the patella. And that's a longer term follow-up. You can see some of those fractures on the fibula. I've also shown consolidation. That had also fractured. And she did quite well. Her story continued and she developed a fracture, but we don't have time for that. So, Parag, yeah, but we'll end over here at this point so that we can continue with the two presentations. Thank you, panel, for your participation.